بسم الله الرحمن الرحيم. بسم الله الرحمن الرحيم. طبعا النهارده برحب باستاذي الفاضل الكبير الدكتور محمد صبح، اللي عودنا في خلال الاسابيع الماضيه ان كل اسبوع في حلقه بنستفيد بها من علمه وخبرته الكبيره جدا جدا. طبعا دكتور محمد من الناس القلائل اللي اتقال اسمه خلاص، مش محتاج تقديم. احنا بنتشرف ان احنا بنقدم الدكتور صبحي معانا، لانه طبعا صاحب فضل على تخصص الكلى وعلينا كلنا. النهارده هو اختار عنوان اعتقد انه عنوان شيق جدا وصعب جدا في نفس الوقت، وانا متاكد ان بالطريقه السلسه بتاعته ان شاء الله هيبقى الموضوع مستساغ وهنفهمه كلنا كويس. Podocytopathy, a genetic and clinicopathological integration. انا برحب باسمكم باستاذنا الدكتور صبح، وعشان ما نضيعش وقته هو معاكم على طول.
بسم الله الرحمن الرحيم. وأنا برضو برحب بالجميع، وبأشكر مرة تانية أخي العزيز الحبيب دكتور حسين شعيشة لهذا المجهود الفائق. ونخش في الموضوع. النهاردة أنا هتكلم في موضوع مهم جدا. We are daily practicing this group of diseases which is podocytopathy. Under the old names اللي احنا عارفينها minimal change, focal segmental and these things. Now, to understand podocytopathy, first, what about proteinuria? What about proteinuria? We know there are different mechanisms to prevent protein leakage from the glomerulus, and the loss of these mechanisms will lead to proteinuria and nephrotic syndrome. We remember that this is the capillary lumen, and this is the urinary space. This is the basal membrane and barrier for proteinuria to occur. And this is the cytoplasm of the endothelial cell, which is fenestrated. And this is the basal membrane, and this is the lamina densa, and lamina rara interna, and this is the lamina rara externa, and this is the podocytes. Against or to prevent leakage of protein, we know there is a charge barrier, which is a negative charge present in the basal membrane, the cytoplasm of the endothelial cell, and negative charge in lamina rara interna and externa, as well as the negative charge present on the podocytes. Beside the negative charge, there is the size barrier, which prevent a large molecule, including albumin, from passage from urinary, from the blood space to urinary space. There is a size preventing larger molecule to pass. The size barrier present in the fenestrated cytoplasm of endothelial cell, size barrier in the lamina densa, and between the food process, i.e. the slit diaphragm. We know that this negative charge and size barrier are created by protein, and this protein are formed by gene. So if there is genetic mutation, abnormal protein formation, leakage of protein will occur, and protein occur in genetic types of nephritis and podocytopathy. So we move to the podocyte. From the previous information, we know that, or we feel that podocyte play the major role in controlling leakage of protein, and consequently, if disease occur in pathogenesis of proteinuria. Since podocyte share with its negative charge in the podocyte, as well as the size barrier in the slit diaphragm. So we have to know some information regarding this magic, the podocyte. You see, this is the podocyte with its food process resting on the outer surface or urinary surface of the basal membrane of the capillary. This is the podocyte. It looks like octopus with these legs, interdigitating legs, resting on the capillary basal membrane to prevent leakage of protein. Okay, go more deeper to the podocyte histology, since we are talking about podocytopathy. If we know that the visceral epithelium, which is the epithelial layer lining on the capillary basement membrane, while the epithelial layer on the opposite side covering the wall of the Bowman's corpuscle, we call it a parietal epithelium. Here we are talking about the visceral epithelium, which is the podocyte. Podocyte, as we saw in the previous figure, have a voluminous body, big body, which bulge into urinary space. And like an octopus, podocyte cell emits thick extension. يعني أرجل أساسية. Then we call it primary. Then the legs gives smaller leg or smaller extension. We say secondary process or foot process, which integrate and cover totally the surface of the glomerular capillary loop. Totally is very important since all the capillary basement membrane should be covered by this podocyte. Otherwise, the area which is bare or not covered will be the source of leakage of proteinuria. This is the transmission electron microscopy. This is the capillary lumen. This is the basement membrane. This is the endothelial cell. It's a nucleus usually to the direction of the mesangium. This is the cytoplasm, fenestrated cytoplasm. And these are the podocytes, octopus-like, with its primary extension. And this extension gives a smaller extension like this, covering the basement membrane from outside. Each cell can cover many capillary, and every capillary is covered by a process coming from different podocytes. So it is well covered. They still have one nucleus, as you see. If we go, this is a transmission electron microscopy. So this is the body of the podocyte. This is the primary extension, which gives a smaller extension, secondary extension, which we call podocyte, covering the outer surface of the basement membrane. More detail so this is the capillary lumen, this is the endothelial cell, this is the fenestrated cytoplasm, and these are the pores. And this is the basement membrane. You see, this is the lamina densa, and inside lamina rara interna, lamina rara externa, and these are the food process of podocyte. More focusing on this area, the filtration barrier, in this figure, you see, this is the lamina densa of the basement membrane, the lamina rara interna, and on it we have this fenestrated cytoplasm, and this is the fenestry, and this is the lamina rara externa, and these are the podocyte. Focus more. Between podocytes are connected with each other by what you call slit diaphragm. This is the slit diaphragm, which we are going to even focus more on the slit diaphragm due to its importance in the story of proteinuria. This is the slit diaphragm. You see, this is the podocyte. This is slit diaphragm. This is lamina rara externa. This is the densa, lamina densa, lamina rara interna. This is the cytoplasm of endothelial cell, and these are the fenestry. So now we imagine very well what is the podocyte, what is the filtration barrier. Thus, the glomerular capillary basement membrane, through its whole length, is covered totally by secondary food process and its slit and their slit diaphragm. Any uncovered point in the basement membrane will be a source of proteinuria. The luminal membrane, i.e. the membrane of the podocyte going to directed to the basement, the capillary lumen, including the slit diaphragm, is covered by a thick surface coat, which is rich in cyano-glycoprotein. We call it podocalyxin. This is a very good, this is a very important name, don't forget it. Podocalyxin having the negative charge. Podocalyxin. Slit diaphragm exhibit a zipper-like structure. Podocyte interdigitating with each other. This, we call it zipper-like structure. And between the extension, there are spaces through which filtration can occur. Zipper-like structure. You see it here. You see this is the zipper-like structure interdigitating extension from cell meeting extension from other cell together makes this zipper structure of the slit diaphragm. This is very important. You know what is the value, what is the functional value of this zipper structure of interdigitating extension from cell with its neighboring cell, making this slit diaphragm. What is the function of the slit diaphragm? It reinforces the capillary structure against tensile force resulting from filtration pressure of about 40 millimeter mercury. So with there is filtration pressure inside the capillary. So it creates, it wanted to make more expansion of the capillary. This zipper structure will enforce the wall, keeping the normal structure of the capillary. Number two, slit diaphragm function as final selective apparatus of filtration mechanism. It is the main determinant of the permeability of the capillary. So keeping the capillary human, controlling the permeability, and also may serve as a principal filter barrier to plasma protein, as I said. This is the function of the slit diaphragm. The overall, what is the function of podocyte? It participates with the endothelial cell in the senses of the GBM, glomerular basement membrane. They are principal cell, the principal cell controlling the permeability quality of the capillary lobe. Number three, they function in hydraulic regulation of capillary lobe diameter, opposing the expansion of capillary lobe and maintaining patency. It keeps it open like this, not collapsing and not expanding more. Control the patency of the capillaries. Okay, now we know the podocyte with extension and slit diaphragm. We have to know some information about the adjacent cell and the basement membrane. Endothelial cell, the endothelial cells line the inner side of the capillary basement membrane. As we know, most of the cell body is located close to the mesangium. You can usually find it at the mesangial side. A thin sheet of fenestrated endothelial cell cytoplasm line the inside of the capillary wall. I show it to you. The fenestrae are rounded or oval, usually 50 to 100 nanometer in diameter. This cell coat is negatively charged and play a part in the prevention of protein leakage due to the presence of polyanionic glycoprotein, including cyano-glycoprotein podocytopathy, again podocytopathy, which represent the major surface polyanion of glomerular endothelium as well as epithelial cell. Okay. Endothelial cell, we know it is very important. It is a big player in our body generally and in the glomerulus especially. Endothelial cell together with endothelial cell contribute to the formation of the GBM. The endothelial cell prevent blood cell and macromolecule from passage from the capillary lumen to the urinary space. Endothelial cell negative charge control the proteinuria, prevent proteinuria. Endothelial cells are active participants in process of controlling coagulation. Similar to platelet, endothelial cells contain component of coagulation pathway and are capable of binding to factor 9 and 10 and also sensitizing and releasing and binding vulnerable brand factor. Of course, disturbance in this side of work or function, we know about HES, hemolytic uremic syndrome, and TTP. Endothelial cell also play a role controlling inflammation and immune process, body defense. And also we know it have antigen similar to monocyte macrophage lineage and express surface antigen in class 2 histocompatibility. So it have a role regarding organ transplantation. So it is very vital cell. Now we discuss the podocyte and the endothelial cell. What about the basement membrane in between? The basement membrane has 3 ultrastructural zones. Lamina rara, lamina densa, this is in the middle. lamina aurora externa between the food process and the densa, and lamina aurora interna between the densa and the cytoplasm of endothelial cell. The thick lamina densa prevent particles equal to the size of albumin or larger from entering in a Bowman space. So it is a filtration barrier, size filtration barrier, while lamina aurora interna and externa are barrier through its negative charge. Okay, we go deeper. Our problem with podocytopathy are dominated by the molecular abnormality in the podocyte. So what about the molecular structure of podocyte? If you understand well, this will be great, since this is important to understand different type of podocytopathy. Also, most of the research or all the research currently and in future are playing with this molecular structure of podocyte. So let us go and understand it. It may look complicated, but inshallah, I will make it easy, inshallah. This is the plasma membrane. This is the lamina densa. This is the lamina aurora externa. This is the podocyte, the extension from the body of the cell. Podocyte cell will be there in the direction of urinary space, and podocyte should be fixed in this site. How podocyte is fixed? It should be fixed to something strong, dense, which is the lamina densa of the capillary plasma membrane. You see, this is the lamina densa. This is the podocyte and its process. How it could be fixed? Look here, like زي السفينة أو المركب عاوزة تثبتها على الشط. Let us consider الشط here is the lamina densa. And the podocyte process is the extension from the boat. How it could be fixed? Here from the lamina densa, there are a protein called laminin and argine laminin. Laminin protein projecting or adherent to the lamina densa. There is another protein here, it's called integrin or dystroglycan. It is attached to this laminin. Then it protrudes through lamina aurora externa and go inside the podocyte. So it fixes podocyte to the lamina densa. Not only this, this integrin have extracellular domain. There is a membrane domain, this one, and intracellular domain. The body, it have to be fixed to something solid inside the podocyte. Okay, the podocyte considered as a tent. A tent. It has to have a skeleton. This hard skeleton. The hard skeleton of the podocyte is made by this row of protein we call actin. So we have actin part. There are two filaments. You see this filament of actin. It is hard, making the skeleton of the podocyte. And this actin is the two row of actin to be more fixed are attached to each other by another protein. We call it alpha actin. So this is actin makes the skeleton. The row of actin is attached together by alpha actin. So to make it a solid backbone of the podocyte. So this protein will be fixed to actin so that to be more fixation, not to be attached to the cytoplasm or to the basal membrane, but attached to the skeleton of the cell by other proteins such as taline, vaccinin, vinculin. So the podocyte is attached by its skeleton through this way to the lamina densa, and also through this way of laminin, dystroglycan, and to another protein, we say utrophin, to the actin. So you know now what is actin, what is alpha actin, what is utrophin, what is taline, vaccinin, vinculin, what is integrin, what is dystroglycan. This we call protein attaching the podocyte to lamina densa, also to be more strong, attached together by what we call sarcoglycan. So alpha sacro, beta, gamma, theta sacroglycan. These are protein fixing these together and fixing it to the skeleton of the cell. As such, the podocyte is very adherent or attached to the lamina densa. But we need podocytes, the row of podocytes are adherent or attached to each other. This occurs through the slit diaphragm. And so these are protein projection attaching podocyte to other podocyte through the slit diaphragm, which you see it later on. How it is attached by nephrin. You will see this nephrin in many congenital kidney disease, proteinuric kidney disease, protein attaching podocyte to podocyte through a diaphragm. So nephrin and also podocene attaching, sharing in the formation of the slit diaphragm. But this nephrin attached with the other nephrin in the opposite side, other podocyte, to be more strong, nephrin is fixed by other alpha nephrin 1 and 2 and 3. So big nephrin attached together, fixed together by this nephrin attached related protein. Okay, but again, the slit diaphragm should be fixed to the skeleton of podocyte. This occurs through CD2AP protein attaching the nephrin and podocene to the actin part of the podocyte. So now, if you hear how podocyte is fixed to cytoplasm, to the lamina densa, you know this protein, you know what's saccharoglobin, what is verculin, what is baxinin, what is stannin, what's actin, alpha actin. Also, this is synaptopodine. Synaptopodine, this is an important protein, play a role also. It is fixing the, have a role with the actin, the cytoskeleton, synaptopodine. What is this? This is the podocalyxin, another protein at the same membrane. It has a negative charge. So this is the molecular structure of the podocyte. Of course, these are proteins which are formed or controlled by gene. If there is genetic mutation, one or more of these proteins will be abnormal. So the podocyte will be unhealthy and will have disease, genetic podocytopathy. This is the a podocyte, this one podocyte of a cell. This is another podocyte. And in between, the, as I said to you, attached together by this zipper-like structure, which is the slit diaphragm. The red part, this is the, as I said to you, the nephrin. And there, as a susta should be fixed from below and from side. This nephrin are fixed by this nephrin 1 and nephrin 2, nephrin associated protein. And here, as I said, to CD2AP protein fixing it to one podocyte and other podocyte. And this is the podocene, this side and this side also. So this is zipper-like structure of the slit diaphragm attaching the podocyte together and playing a major role in the filtration process, as I said to you. Now, a few words about this protein, important protein, nephrin and nephrin-like protein. This is the nephrin, have a role regarding formation of slit diaphragm, is the most important structure and component of the slit diaphragm. Nephrin has an extracellular domain. This is the extracellular domain, and the cytoplasmic domain, and intracellular domain. Slit diaphragm proteins such as nephrin-like protein, nephrin 1, nephrin 2, and 3 were shown to stabilize the slit diaphragm structure. As I showed to you, these are nephrin-related protein. This is the nephrin, okay. Now we are talking about the podocene, the same. This is the podocene, okay, okay, forming the slit diaphragm, and this is the protein fixing podocene, the same. Okay, now we know the filtration barrier, endothelial cell, basement membrane, podocyte, nuclear structure podocyte, slit diaphragm, zipper-like, nephrin, podocene, and this story of molecular structure. How the glomerulus is formed. the development. Since if we talk about podocytopathy, especially genetic podocytopathy, we have to know some information about the development of the glomerulus. And this in brief or shortly, this is how the glomerulus is formed. This is the Wolffian duct, which make, of course, the ureter, renal, and pelvis. And Wolffian duct, there is protrusion of the Wolffian duct we call ureteric bud. This ureteric bud will form the, as we will know later on, the collecting duct. This protrusion invade metanephric mesenchymal cell. This is stem cell which makes the nephron. Scattered cells here, it is invaded by the ureteric bud. After invasion, this mesenchymal, metanephric mesenchyme will make a cap like this. It is stem cell. Then it makes a vesicle like this. We call it renal vesicle. This is going to form the nephron. This is going to form the collecting duct, as we are going to see. The vesicle later on will take a form coma shape. We say coma shaped body. And then it will become S-shaped body. If we come to the, for example, nephrotic syndrome, first year of life, sclerosing glomerular in kidney biopsy, you can see this S-shaped bodies. Then S-shape will make this tubule. This is the distal convoluted. This is the proximal convoluted. This is the Bowman's capsule. So this is the part of the nephron. And then invagination by capillary, which will make the tuft of the glomerulus. Okay, more shapes. This is how the ureter, pelvis, minor calyces, more minor calyces, then the collecting ducts, and here the invasion of the mesenchyme. Okay, this is the cap, this is the comma shape, S-shape, then the nephron, and invagination by capillary. This is how the nephron is formed. So this, it is the same repetition. This is the capillary, vesicle, S-shape, cell, stem cell going to form the more. And here, this is the glomerulus is formed. And you see the capillary invaginating the Bowman's capsule. This is the stem cell, mesenchymal stem cell, or we say renal progenitor, which make the tubule and the Bowman's capsule. And here, there is podocyte progenitor, here from this wall. These cells are going to make the parietal epithelial cells, but also the podocyte will come from here. So if we are talking about crescentic glomerulonephritis, there is proliferation of this progenitor of podocyte, to make the crescent. More shape to say, this is the ureter, pelvis, minor calyces, and these are the collecting duct. And this is the renal vesicle, comma, S-shape, and this is the nephron formed. This is a cross-section. What is the nephrogenic zone? This is the capsule of the kidney, and here is the medulla. Usually, the genesis of the glomeruli start in this zone. We say it subcapsular zone. We say nephrogenic zone. It is the area of nephron formation, and the more formed glomeruli, it will be more deeper. So if you have a patient with nephrotic syndrome, congenital nephrotic syndrome, if you look to the outer glomeruli, you will see the S-shape, head shape of the immature glomeruli and immature podocyte. You see these cuboidal cells, this is immature podocyte. Subcapsular nephrogenic zone is present in the kidney until approximately 8 days of life, then become mature. This zone contains tissues which interact to produce a new nephron and interstitial tissue. Beneath the nephrogenic zone, renal corpuscle of increasing maturity are located at successive deeper cortical area. What is the value of this information? If you are able to do biopsy in a patient with congenital nephrotic syndrome, look to the subcapsular glomeruli, you will see the abnormal shape. This is the S shape, then it will make circle like this. We call it, this is the head shape. The Bowman's capsule take this like comma shape, and the capillaries started to form, actually, but no capillaries yet. This head shape will give this capillary loop shape, start to make loops like this, and this is a mature glomerulus. Go here, this is a biopsy from a child with nephrotic syndrome. This is the S shape. This is S shape. This is the head shape, like this one. You see, this is the head shape. It is clear. Look to the this is podocyte. It is cuboidal shape, not yet mature podocyte. You will see it in the subcapsular glomeruli in patient with congenital nephrotic syndrome, cuboidal in shape. Now, this abnormal protein in the podocyte, it is controlled by gene. What are the genes playing a role in podocytopathy? There are many genes. The most important of them is, we say, Wilms tumor 1 protein, of course, gene controlling this protein. All renal progenitor, the cells which form the nephron, express this gene, Wilms tumor 1 gene, during early development, but on nephron maturation, it is limited to podocyte. It vanishes from the nephron. It is a master regulatory gene. It regulates expression of key protein by podocyte, including nephrin and podocyte and podocyte differentiation. Altered this gene and consequently its protein content are noted in genetic and acquired form podocytopathy. Arrested maturation at the head stage, now we know what is the head stage, causing diffuse mesangial sclerosis and collapsing glomerulopathy. Another gene, we say BAX2 gene, is another transcriptional regulator related to Wilms tumor 1, which regulate early kidney development. As the glomerulus mature, the expression of BAX2 decrease, while Wilms tumor increase in podocyte. Persistent expression of BAX2 is implicated in the development of nephrotic syndrome. Down-regulation and persistent, it is a prerequisite to its disappearance, vanishing is important for podocyte differentiation. LMX1P gene is first expressed in podocyte precursor cell. You saw the podocyte precursor cell, the cuboidal, very basophilic cells of S-shape. Now we know what is S-shaped body, and continues to show this expression throughout nephrogenesis. Mutation of this gene will cause nail-patella syndrome, in which we have dystrophic nail, hypoplastic patella, and nephrotic syndrome. There are other very important genes. We say gene encoding submembranous actin cytoskeleton, yeah, which control this actin, or actin 4, which connect actin 4. Okay. Gene encoding protein component of slit diaphragm. Here we are talking about slit diaphragm. Nephrin 1 gene that encode nephrin. Its mutation is responsible for venous type of congenital nephrotic syndrome. Nephrin S2 gene encode podocin. This is the podocin. Its maturation is responsible, its mutation is responsible for development of autosomal recessive steroid-resistant nephrotic syndrome. Gene encoding protein component of basement membrane collagen. Now we are talking this basement membrane collagen, type 4 collagen. We remember Alport syndrome. There are this contain only type 4 collagen. There are many mutations which can cause Alport syndrome, but also can cause congenital focal segmental glomerulosclerosis. Now we leave this basic information and we go more into practical day life information. There is a damage to podocyte, whether due to genetic mutation and consequently abnormal protein formation, or damage by any other mechanisms, inflammation, drug, toxin, or anything. What happens if the podocyte are damaged? There are, this will take one of 4 different pathways. Podocyte will take one of 4 different pathways, and consequently causing different type of disease. Food process effacement, you know, this food process was like this, then it become effaced. Without significant change in podocyte number, the number is the same. When this occur, the glomeruli generally appear normal on light microscopy, as in case of minimal exchange nephropathy. But if you do electron, you will see food process effacement. This is the most benign type of injury. But if injured podocyte enter apoptotic pathway, podocyte will die. And the number of podocyte per glomerulus decrease, what we call podocytopenia. There are many ways to count podocyte in research, but I am aware now Dr. Fatima Hussein is doing some stains, which is very practical and can be done in minutes to count podocyte. This is not now the time to say this. So podocyte, if counted, there is podocytopenia. Podocyte deaths lead to focal segmental glomerulosclerosis. So there's a difference between minimal change and focal segmental. Here, number of cells is the same, and just podocyte only fusion of effacement of podocyte. Here there is a detachment and death of podocyte, more severe disease. Or podocyte is there, but there is developmental arrest, stop maturation. If injury occur early in life, glomeruli maintain an immature appearance. You remember the immature appearance of podocyte, which I show you in the head stage, for example, as reflected by mesangial expansion and crowding of podocyte. Podocyte will be crowded, not arranged in this marvelous shape, which may express a low proliferative activity and diffuse mesangial sclerosis. Diffuse mesangial, you have a developmental arrest, usually present in early life, mesangial sclerosis. Or podocyte dedifferentiation. It starts to dedifferentiate. You will see multinucleated podocyte, and it proliferates quickly. Morphologically, this phenomena translates into collapsing glomerulopathy. So podocyte injury will give one of these 4. The very benign, which is the minimal change, podocytopenia, arrested development and mesangial sclerosis, more proliferation and dedifferentiation, and collapsing glomerulopathy. So consequently, what is the pathology? It will be either, as we said, injury of podocyte will give us either minimal change, focal segmental, diffuse mesangial sclerosis, or collapsing. And it is not, any of these is not one disease. It could be congenital or acquired, primary or secondary. This is the 4-type podocytopathy. This is the minimal change type, focal segmental type. This is diffuse mesangial sclerosis type, and this is the collapsing. You see the capillaries are collapsed of the tuft, and all these are proliferating podocyte. Okay, so we go more into the clinical side. Introduction was long, but to understand well what is podocytopathy, not only in clinical practice, but also to understand what about the research going currently and in future regarding podocytopathy. You have to know this introduction, long introduction. Now we go into the heart of clinical practice. by definition, what is podocytopathy? Podocytopathy are group of glomerular disease in which proteinuria is attributed to damage or dysfunction of podocyte. Okay, it is group. Being group, to understand it, you have to classify. What is the classification? The classification could be, to be beneficial, either be pathogenesis related. So you understand the pathogenesis of this disease which you are dealing with. Consequently, you can treat better. Also, according to the clinical response, this is steroid sensitive, steroid resistant, frequent relapser, is another classification. Or you classify according to histopathology, according to the histopathologic finding, according to the kidney biopsy. And this is the classification depending on the pathogenesis. This table, it may look as if it is complicated, but actually I will make it very simple. Since if you understand this table, you will understand what is podocytopathy in one punch of information. Okay, this is the pathogenesis. What are the different types of pathogenesis? The first group is the permeability factor-related podocytopathy. What is this? It is a group of disease. What is this? There is circulating factor causing podocyte injury. So it is present in circulation. What is the pathology? It comes as minimal change or focal segmental. But the very prominent in these two types of pathology, there is extensive food process effacement. Okay? What is the clinical? Very important. Sudden onset nephrotic syndrome. When you see a patient comes sudden nephrotic syndrome, this is mostly podocytopathy of minimum or focal segmental, mostly the permeability factor. What is the treatment? It will be, so far there is antibody or immune factor playing with the podocyte, it is immune suppression. Or to do plasma exchange, you remove this circulating factor. What about if the patient go into renal failure and he is transplanted? What about recurrence? Here the recurrence is very common since the patient have in his circulation already circulating antibody. So once you put a new graft, antibody will fix to the food process and proteinuria occur. It can occur even on table. Patient comes to the ward with his proteinuria, new proteinuria, very aggressive, or it can appear at any time, but it can come with sudden proteinuria post-transplantation. So this is the group of podocytopathy, which you understand now. If we say podocytopathy, permeability related, you know what is this. The second group of pathogens is toxic. And toxic could be infection, such as viral infection, or drug or toxin related, causing damage to podocyte. This could be a direct toxicity by the material, such as bamidronate toxicity, or cytokine release due to infection, for example, HIV. There is relation with this type, especially this type, and mutation in APOL1 gene overexpression. And I'm going to explain this in more detail. So this toxic type of podocyte injury, how it presents clinically, usually also focal segmental, minimal change disease. But focal segmental, when it comes here in this in toxin, usually it is collapsing variety, which is a very serious one. Also, in this type of toxic injury, such as HIV, lupus, and this thing, there is endothelial tubulo-reticular inclusion. So this is the pathology. Clinically, this is variable clinical course. Here it was sudden onset nephrotic, is variable, slowly progressive chronic kidney disease, nephrotic syndrome, and these things was the treatment. removal of the toxic injury. If you have CMV, treat CMV. If you have HIV, treat HIV. If you are giving a drug, remove this drug. Recurrence, possibly it may recur if the causative agent is still there. So this is the second group. Then the third group, this is genetic group, for which we gave this a big introduction. Mutation causing structural or functional abnormality of podocyte. Gene mutation will give abnormal nephrin, for example, with abnormal podocyte, with abnormal actin, and so on. It causes minimal change or mesangial sclerosis or focal segmental. Clinically, of course, these things cannot be differentiated from non-genetic. As I'm going to say now, you need genetic counseling. Clinically, it comes as steroid-resistant nephrotic syndrome. So treatment rely on RAS blockade. I'm going to give more detail about this, and if still there is a role to immune suppression or not, I'm going to talk about this later on. But if there is a disadvantage for this type of disease being unresponsive to treatment and progress to renal failure, it has the advantage of no recurrence or rarely it recurs after kidney transplantation. The fourth group of podocytopathy, according to the pathogenesis, is hyperfiltration related. There is adaptive change due to excessive nephron workload. There is damage of big part of the kidneys, loss of many nephron. So the remaining nephron are hyperfunctioning, hyperfiltrated, trying to adapt and to do the function of the whole kidneys. And of course, this is stress causing usually focal segmental, not minimal change. Focal segmental, and here, focal segmental usually very higher. I'm going to say and explain why it is very higher, especially. And here, the effacement is not massive like this. It is usually segmental. Part of food process effacement is partial. It's slowly progressive, proteinuria and kidney damage. What can you do? RAS blockade to prevent hyperfiltration and to stop this adaptive overwork to keep this remaining nephron function. Of course, after transplantation, if renal failure occur, no recurrence occur in hyperfiltration injury unless the cause is due to obesity. And obesity is still persistent after transplantation. It can recur. Now we give more information, more detail about the permeability factor type of podocytopathy. This very interesting finding was a long time, have been discovered a long time by Shalhoub group. They observed it in patients with Hodgkin lymphoma presenting with nephrotic syndrome. When these patients develop measles, the nephrotic syndrome disappears. And measles is known to damp activity of T activity. So they said mostly this T overactivity producing certain factor causing nephrotic syndrome is the cause of nephrotic syndrome. And they put their hypothesis of permeability factor produced by T lymphocyte. This was the evidence and the theory. But stronger evidence came later on. For example, in our patient with focal segmental glomerulosclerosis after transplantation, some of them will develop recurrence. And the recurrence occurred immediately after implantation. So there is something ready in circulation to cause this permeability, this proteinuria. We call it a factor in circulation causing permeability loss and proteinuria. So they call it permeability factor. This is a strong evidence. And commonly we see this in our practice. And in our management, we play with this permeability factor by plasma exchange, for example. Another evidence came, which of course this is rare, but it came by chance. When they transplanted the patient, we know he has a nephrotic syndrome. And once the kidney was there, massive proteinuria occurred. They know the outcome is poor from this kidney. They had, those who reported this observation had at the same time another donor ready to receive, but was unlucky. Now they tried with him. They removed this kidney, explanted it from this bad recipient and put it in this new one, retransplanted. This one have not a focal segmental patient, and the kidney after being proteinuric, it came normal. So there was something in the circulation of this patient number 1, which is missing in patient number 2. Since these are the evidence for what we call permeability factor causing this type of nephrotic syndrome. What is the permeability factor? There are several molecules incriminated, including soluble urokinase type plasminogen activator receptor, cardiotrophin-like cytokine factor 1, and CD40 antibody to this, have been proposed as circulating factor that cause podocyte injury. But we still don't have a convincing candidate that can be measured and followed up in clinical practice. And here I'm putting this alamat ta'aggub. Why? We have this hot problem, long time, occurring in many patients, not to be able to identify this factor with this scientific armamentarium we have, this big pity. I have suggestion of research work I'm thinking with my colleague. There is a report which says that if you take serum from this patient with focal segmental and you inject it into mice, it will develop proteinuria. Why not use this as a biologic marker? We have mice and we have patient who is going to be transplanted. Why before transplantation we take some of his plasma and inject it into mice and we look for proteinuria? If there is proteinuria, we know recurrence will occur, and we put our plan on this. And after transplantation of this patient, we can follow his serum for this circulating factor, not by ELISA or PCR or this thing, but biologic test, mice. This is a research idea, which could be logic or unlogic, but we consider it food for thought. We are thinking to have if there is no chemical marker by ELISA in this test, why not to search for a biologic one? You remember the story of anti-GBM. To diagnose anti-GBM, you take serum from your patient and put it on a normal kidney tissue and you look for the deposits. Okay, another story, but part of brainstorming. In terms of clinical presentation, this permeability factor, podocytopathy, it presents a sudden nephrotic syndrome. If we go to transplantation, early recurrence, as I said to you, even on table. If you do biopsy, you will have minimal change at the start, or you have any variant of focal segmental. Any variant. Initial responsiveness to immune suppression and plasma exchange usually occur. Usually, if we have transplant patient with this recurrence, we give more immune suppression and we do plasma exchange. But unfortunately, after remission is induced, the patient will relapse. And we are working, playing game with the patient. We do remission, then he relapses later on. We do plasma exchange, remission, and then so on. Very expensive story. We leave the permeability factor and we go to more detail about genetic form of podocytopathy. Genetic variant of protein due to genetic mutation that form the glomerular filtration barrier can cause focal segmental, minimal exchange, or mesangial proliferative, or we say diffuse mesangial sclerosis. These are these 3 types common. Genetic testing is the only method to diagnose this form of podocytopathy and should be considered in patient. We cannot do it in every patient. It's very expensive and tedious, but you can do it at least in patients with family history of nephrotic syndrome or family history of non-nephrotic proteinuric kidney disease, as well as patient coming with a syndrome, extrarenal manifestation, we call syndromic patient. So this is the indication for genetic testing. Currently, actually, genetic testing is available for research work, but we hope that with declining cost and easier access to genetic screening, may soon, we hope it will be soon, make this a standard part, as a standard part of practice in all patients with podocytopathy. Since as we know, genetic podocytopathy is not for, in children only, it can occur in adults. In some instances, knowing type of mutation present may guide treatment, such as mutation causing coenzyme 10 abnormality, I will show you this, or mutation causing B12 deficiency. Discovering this, it can help us to do some management. But the more important, if you know this is a genetic form of focal segmental or minimal change, you you avoid using aggressive immune suppression. Not only cost, but for the side effect of these immune suppressive drugs. And these are practice actually when we have a patient who is minimally changed and you give a steroid, no response, you start giving him cyclosporin or MMF, no response, you give him rituximab, and at the end, this is genetic form of minimal change. If you know this from the start, you can avoid this cost and these side effects. This is an important piece of information, which is mutation in type 4 collagen gene, collagen 4A gene. This is a very common, and we know it causes Alport syndrome. Many of, maybe the most common, you see 4 to 57 cause of genetic focal segmental in adult. Actually, we are talking now not about Alport. Actually, when I gave the lecture of hematuria in our patient, we found that cell-based membrane and Alport syndrome were the commonest in patients presenting with isolated proteinuria. Here, the same gene can cause focal segmental. And recently, I had a patient with nephrotic syndrome, and I'm treating her over 15 years as minimally changed. Actually, the course was steroid responsive, but frequently relapsing. So I did kidney biopsy and I did electron microscopy. It came as Alport syndrome. Okay. It is estimated that collagen mutation account for nearly 30% of genetic form of a chronic kidney disease, CKD. Now we are talking about CKD, chronic kidney disease general, not only nephrotic. Although many affected patients are not diagnosed as having a hereditary condition. Daily we see patients coming with proteinuria and CKD, and we don't do investigation since the patient is coming late. Big list of gene which has been discovered to have relation with genetic podocytopathy, and by time they are adding new discovered gene. But if you come to the commonest, I will say to you the commonest gene is the collagen 4 A3 or 4 or 5, which affected the cell-based membrane, the lamina densa, type 4 collagen. It could be autosomal dominant, autosomal recessive, or X-linked. It causes Alport syndrome, and you know the criteria, clinical criteria, Alport syndrome, eye, ear deformity. These other mutations, such as a nephrin, S1 affecting nephrin, slit diaphragm, causing early onset steroid-resistant nephritic syndrome, nephrin S2, the autosomal recessive, affecting podocyte, also the slit diaphragm, causing early or late onset steroid-resistant nephrotic syndrome, many other genes, and gene even causing syndromic, such as this causing Charcot-Marie-Tooth and many syndromes. But if you come here to this Kupin deformity, this causes megaloblastic anemia, and B12 deficiency. If you diagnose, you can treat this. And this CoQ3 causing coenzyme Q6 causing sensory neural hearing loss and nephropathy. So this is the different gene causing genetic type of podocytopathy. About 60% of patients with steroid-resistant nephrotic syndrome who manifest the clinical sign of disease in the first year of life have genetic cause of podocytopathy. No treatment. This is the black side, but one side of the coin. To me, I look to the opposite side of the coin, that in 40% of patients' first year of life, you have non-genetic causes. So still you can treat. Still you can give immune suppressive drugs and calcineurin. Don't say this is the first year of life, it is genetic. No, 60% you are right, 40% you can treat. Of course, this number, 60%, decline as the patient present older. Typically, this genetic form comes as steroid-resistant nephrotic syndrome or proteinuric non-nephrotic CKD. Now we come to the immune suppression. Is immune suppression have a role with genetic? Of course, I say no steroid, no anti-proliferative drug as cyclophosphamide and MMF, no. But come here, the calcineurin. Although cytoskeleton stabilizing effect of calcineurin inhibitor, cyclosporin and Prograf, can lead to reduction of proteinuria in some patients. So still, it is genetic. But if he is coming by massive proteinuria, we know the proteinuria per se is damaging to the kidney, to the nephron. So if you give antiproteinuric, it can help prolongation of the survival. And this is what we do with ACE and R. But also, cyclosporin can decrease proteinuria. So still you can use it. And it can cause remission in patients with genetic nephrotic syndrome. But the backbone of treatment is RAS blockade to decrease proteinuria and consequently renal fibrosis due to antiproteinuric, antifibrotic. We know the recurrence after transplantation is rare. Now we discuss the permeability factors as pathogenesis, the genetic story, and now we come to the toxic podocytopathy and Apollo and its relation to apolipoprotein 1 genetic mutation. These toxin either drug, such as bamidronate, infection, such as HIV, or hematologic malignancy, and systemic inflammatory state, all can cause toxic podocytopathy by varied mechanism. Collapsing glomerulopathy is a frequent pathologic finding in toxic podocytopathy, but of course, minimal exchange and other form of focal segmental can be there. One of the most well-described infection-related podocytopathy is HIV. It causes what we say HIV-associated nephropathy, which causes virus-induced cell proliferation in podocytes especially. Classically, it manifests as collapsing glomerulitis in patients with poorly controlled HIV infection. The majority of patients who develop HIV-associated nephropathy are African descent. This racial disparity has recently been explained in a large part by genetic variation in Apollo gene, for which gene product, normally in African, living in Africa, for example, this product have a defensive mechanism, especially the G1 and G2 risk allele of Apollo 1 increase resistance to trypanosoma brucei. This is parasite which cause sleeping sickness or trypanosomosis. So it is advantageous, but here it is a risk factor. This detrimental effect of having two risk allele, G1 and G2 Apollo, is increased susceptibility to HIV. They develop HIV more, and they develop focal segmental more. And all hypertensive kidney disease is more in African American, having this 2 risk allele, and other form non-diabetic CKD is more serious with genetic due to this genetic mutation. The problem is big. Don't look only to the African American, but those living in Africa, they have this deformity, this mutation. About 10 to 13% of African American carry a 2 risk allele, and among this big number, 20% of these double carrier develop kidney failure. You see, big number. So if you go to renal failure, it will be much more in African Americans than white American due to this 2 risk allele. This incomplete penetrance, not all will develop this disease, suggests that a second hit or injury process is required for Apollo-related kidney disease to develop, such as he have the risk allele, but he's waiting for a hit, such as HCV infection, for example. Another type of podocytopathy, genetic podocytopathy, there is a full penetrance. All, if not most of, if not all, having deformity will develop disease, full penetrance. Another story other than HIV, now we come to interferon, and we know interferon story in our patient, HCV. You remember with interferon, we got patient having nephropathy. Yes, interferon is associated with collapsing glomerulonephritis, with endothelial tubular reticular inclusions, and retrospective genetic analysis revealed that many patients with these interferon-associated lesions have 2 risk allele of Apollo gene. Good. Another toxin other than interferon, bamidronate intravenous infusion, is used for multiple myeloma treatment or malignancy-associated hypercalcemia. It can cause podocyte injury. Unlike HIV-associated, the risk of developing bamidronate-associated focus segmental is not related to race or ethnicity. Anyone can develop it. Additionally, tubular reticular inclusions are not frequently seen on biopsy, suggesting a different mechanism of injury. Of course, if we know the agent causing podocytopathy, whether drug or toxin or infection, if you diagnose and we treat, we can treat podocytopathy. This is an interesting paper which has been published in 2015. It was a review talking about drug-induced glomerular disease, direct cellular injury. He says that usually if we say drug-related kidney disease, usually it is tubular interstitial, either causing acute tubular necrosis such as amyloidoglycoside induced, or acute interstitial nephritis as many drugs can induce. But here they are looking for drug-induced glomerular diseases. And the drugs can cause either epithelial injury, podocyte injury, causing minimal change, or focal segmental. And this is a drug which can cause minimal change as interferon, bamidronate, lithium, non-steroidal anti-inflammatory drugs. Focal segmental, the same, interferon, bamidronate, lithium, but here sirolimus and anabolic steroid. Remember the patient taking anabolic drug for bodybuilding can develop this podocytopathy. Or the injury can affect the endothelial cell, causing thrombotic microangiopathy, such as with mitomycin C, antiplatelet drug quinine, or affect the mesangial cell, causing nodular glomerulosclerosis, such as what's seen or reported with heavy tobacco smoking. And this is a photograph showing collapsing podocytopathy in patient treated with bamidronate. You see the collapsed capillary, and you go and see to this podocyte. Podocyte is large. Podocyte, you see it here, swollen and proliferated podocyte. So with collapsing, there is collapsed capillary, wrinkled and collapsed capillary, and proliferation and enlargement podocyte. This is another case of interferon beta treated patient. for treatment of multiple sclerosis. And by light microscopy, everything was normal. But by electron microscopy, see, this is the capillary in human, and this is the plasma membrane. This is the podocyte. Where is the food process? There is complete effacement of the podocyte. This is the podocyte. So it is minimally changed nephritis in patients treated by interferon. We come to the last group, hyperfiltration mediated or adaptive focusing. Here it is mainly focus segmental. When there is a reduced total number of functioning nephron due to either acquired disease, any type of kidney disease causing damage of nephron, and there are remaining healthy nephron, these remaining healthy nephron are hyperfiltrated, hyperfunctioning, or congenital anomaly causing damage, or hyperfiltration by remaining nephron. Hyperfiltration by remaining nephron is adaptive in that adaptive means preserving the physiologic homeostasis. However, the glomeruli and expense will be hyperfunctioning, hyperfiltrated. And this is the cause of death of this glomeruli. Adaptive glomerulopathy can progress to segmental glomerulosclerosis. You remember, each capillary should be covered totally by the podocyte of food process. If the capillary enlarge and enlarge and enlarge due to hyperfiltration, the podocyte cannot cover completely this enlarging plasma membrane. So there is part which are not covered by podocyte, just mechanical. So proteinuria start to occur. Besides, of course, other mechanism causing kidney damage. This has been seen in reflux nephropathy with obesity, and I'm going to give more detail with obesity, and second cell anemia causing scarring in the kidney due to infarcts and consequently hyperfiltration of remaining nephron, or solitary kidney due to any nephrectomy for any cause, due either to renal agenesis or surgical removal of one kidney due to tumor or for kidney donation. Hyperfiltration mediated adaptive focus segmental typically manifest with proteinuria. Here, without nephrotic syndrome, usually come with proteinuria, and no massive or marked hyperalbuminemia and edema. Of course, this is not the rule, but there are exceptions. Actually, I saw a patient with morbid obesity and is coming with this nephrotic syndrome, and when he did bariatric surgery, this proteinuria disappeared completely. So you say this is a rule, but there are exceptions. Sometimes even I have many patients with obesity with full nephrotic syndrome, but this is exception, of course. The usual biopsy finding include glomerulomegaly. This is very important and characteristic, and very higher variant. You know why very higher? On light microscopy, with segmental food process effacement on electron microscopy, I will let you know why it is segmental, not diffuse. Not all patients with obesity and solitary kidney, including kidney donor, develop focus segmental. Some patients will be very obese and no proteinuria. Others will have proteinuria. Why? Let's look to the pairs weight. If there is low pairs nephron, this subject will be subjected for hyperfiltration injury. The lower glomerular density, the higher the risk of hyperfiltration injury. Of course, treatment, if you have a cause to remove, this is number one for obesity, for example, bariatric surgery. Those very obese patients, no way to treat their obesity other than bariatric surgery. This is what I believe. Treatment of hyperfiltration mediated focus segment should focus on reduction of glomerular hyperfiltration through inhibition of angiotensin II mediated efferent arteriolar vasoconstriction. Since you know, to increase filtration of the glomeruli, you do afferent dilatation and efferent vasoconstriction. I will show you this afferent dilatation. To treat, you do efferent dilatation to decrease the pressure inside the glomerulus. Consequently, you decrease filtration pressure of the protein. You decrease proteinuria by this way. Besides, of course, this ACE and R have anti-fibrotic action through an action on TGF-beta. Of course, the key is weight loss in obese patient. This an interesting article was published in 2016 talking about obesity-related glomerulopathy, clinical and pathological correlation and pathogenesis. But we have to remember this table, the definitions. Normal weight, we know, from 18.5 to less than 25 kilogram per square meter surface area. Below this, you are underweight. Within this, you are normal weight. Above this, you are abnormal weight. Overweight from 25 and below 30. Obese above 30. But this obesity could be class 1 from 30 to 35, class 2 from 35 to 40, class 3 obese above 40. This is a definition. Actually, if we come to the key point in this paper, the incidence of obesity-related glomerulopathy is increasing in parallel with the worldwide obesity epidemic. Pathologic features include glomerulomegaly, as I said, and as I'm going to show you, and focal segmental, which usually, as I said, perihilar. Food process, which is partial. Subnephrotic proteinuria, as I said to you previously, with exceptional cases presenting with nephrotic syndrome. Major renal physiologic response to obesity include glomerular. We know filtration rate is increasing, plasma flow increasing, sodium reabsorption is increasing, obesity is a disease. Adipokine and ectopic fat accumulation in the kidney promote maladaptive response of renal cell to mechanical forces of hyperfiltration, leading to podocyte depletion, proteinuria, focal segmental. Of course, therapeutic intervention using renin-angiotensin system and decreasing weight and the new anti-lipidemic drugs are the key for treatment. This is very interesting. See this? This is the glomerulus in obese patient. Compare it to glomerulus in normal one. There is nephromegaly. And here, this is the focal segmental. This is the hilum. And this is the tip. This is the beginning of the proximal convoluted tubule, tip portion of the glomerulus. And this is the hilum where the afferent come. The lesion mostly in the hilar region. You know why? This is the photograph showing afferent. You see this afferent artery is very dilated. As I said to you, to make this glomerulus more working, more hyperfiltration, more functioning, increasing the single GFR, single nephron GFR. There should be arterial vasodilatation, afferent and efferent vasoconstriction. And this is the dilatation of the afferent. And you see the capillary at the hilum is dilated, open. So usually the lesion here, the stress is here. So it is very hilar. And podocyte stress is here. So the effacement will be partial in this area, not in this area. So this is why it is very hilar and effacement is partial. The afferent artery is dilated. This table could be complicated, but it's easy and interesting. It differentiates between focal segmental, primary variety, and due to obesity related. You see the age, of course, obese, usually middle age, with exceptions, of course. We have children who are morbid obese, but also you need time for focal segmental to occur. So usually middle age, but here children and adolescents, usually primary focal segmental. This is age. Clinical presentation, of course, slowly progressive proteinuria. Here, nephrotic syndrome. Proteinuria and serum albumin, of course, here we are subnephrotic. Here we are nephrotic with heavy proteinuria and hypoalbuminemia. Full nephrotic syndrome as I said, only 5% of cases. In here, most of the cases. Clinical course, here, full nephrotic syndrome. And you see at 5 years, 50% of your patient lost kidney. And at 10 years, 25% still having kidney function. But here the story is more benign. At 5 years, you have 75 are okay, still okay. And at 10 years, half of your patients are still okay. So this is more severe and aggressive here. Glomeruli was focal segmental, of course, not all the, fewer have focal segmental. Here, most have focal segmental. Variant here, per higher, in any type can okay. Glomerulomegaly, of course, here and not here. Food process effacement, only 50% or less are effaced. Here, more than 50% of the glomeruli are effaced. So this table can differentiate between obesity and focal. This is not strange, since you may have a patient with obesity, but he have primary focal segment. So in obesity type, you will not give immune suppression. But if this obese have primary focal segment and you missed it, you missed a chance of treatment. So yes, obesity related, different from primary. But obese patients usually have obesity related, but can have primary focal segmental. So please, not every patient coming to you with focal segmental and say obesity related. No, it could be primary. So look for biopsy, look for the data, and diagnose properly to treat properly. If we leave the, we come to the another way to classify. This we classified podocytopathy according to the pathogenesis. So we understand the disease from this side, and we can treat properly. Another way, they can, and also this is reported in this paper in 2020, they classified according to the response. He say steroid sensitive, steroid resistant, nephrotic syndrome, steroid sensitive, focal segmental, steroid resistant, focal segmental. For example, this is the classification. What does it mean steroid sensitive? It means that the patient responded to steroid treatment within 4 years, 4 months. Resistant means in spite you are giving proper dose, steroid treatment, no response up to 4 years. This is steroid resistant. What is the meaning of steroid dependence? Steroid dependence, you stopped steroid within 2 weeks, he relapsed. So give steroid again, steroid dependent. Frequent relapse, i.e. the patient received, suffered from 2 relapses within 6 months of initial response. Or 4 relapse within 1 year. This is frequent. Infrequent, the same definition, but instead of 2 relapse, we say 1 relapse. And instead of 4 relapse in a year, we say 1 to 3 relapse. Remission, by definition, this big story. When you say remission, less than nephrotic proteinuria, say remission, but remission, complete or partial, is another way to define. So classification of a nephropathy in focal segmental, you can say steroid resistant or steroid sensitive nephrotic syndrome. The third way to classify is depending on the pathology. You can say this patient has minimal change, minimal change is the most common histopathologic finding in nephrotic syndrome in pediatric, but astonishingly also in geriatric above 80, minimal change is common. So not every elderly patient you say this is malignancy related, it could be minimal change. Actually, I have patients like this, elderly, and I searched for all marker of malignancy, it came negative. When I gave a steroid, he responded dramatically. In spite he is more than 80 years. Light microscopy and immunofluorescence all show normal finding. It is only electron microscopy which will show diffuse effacement of food process. And this photograph is very interesting. You see this. This is the capillary lumen. This is the podocyte. Where are the podocytes? No, all podocytes are effaced. You see this? This is a classic minimal change with diffuse effacement of food process. If we come to focal segmental, it is segmental lesion, segments and affected glomeruli are focal. Focal segmental is the definition of focal segmental. Characterized by intracapillary penetration by matrix accumulation and hyaline deposits. It is the most common kidney disease biopsy finding in, take care, biopsy finding in adult age from 18 to 80 years with nephrotic syndrome in the United States. But take care, he say biopsy. Possibly you have another patient with minimal change, not biopsy. He say biopsy. The incidence rate of focal segmental is increasing for unclear reason. Focal segmental lesions are classified according to histology into tip, according to where is the sclerosed part of the glomerulus. Is it at the tip? And tip we mean at the site of the proximal convoluted tubule, junction with the glomerulus. So we say tip is the most benign form, or hyaline, as I show you in obesity related near the hyaline or blood vessel, or cellular, in which there is focal segmental besides some cellularity in the mesangium, or collapsing. There is collapse in the capillaries and proliferation in podocyte, or not otherwise specified. You find sclerosis in an area which is not tip or hyaline, and it is not collapsing and not cellular. You say not otherwise specified. As this is the glomerulus, this is the hyaline, this is the tip, and you have this area, sclerosed area. So you say is it not otherwise specified. But this you see, this is a tip lesion at the end of tubular and proximal convoluted tubule tip lesion, the best one. And this is the collapsing variety. You see the capillaries are collapsed, basal membrane is wrinkled, and you see this podocyte proliferation. This is the collapsing variety. You see here, these are the capillary lumen. This is the basal membrane, and this podocyte. It is detached podocyte. Podocyte detachment. Podocyte detachment, there is effacement, yes, of food process. But once the detachment is there, you are not dealing with a minimal change. Podocyte, you are dealing with focal segmental. And actually, there is, I think, also Dr. Fatma Husseini doing a work on this by light microscopy. If you detect this detached podocyte, you diagnose focal segmental, and she's doing a certain special stain and correlating this with electron microscopy. A big work, and MEDC is, I think, to one of our juniors in Department 3. The very higher variant of focal segmental is frequently associated with hyperfiltration injury, with obesity, for example. The tip variant, also referred to glomerular tip lesion, commonly manifest as steroid-sensitive nephrotic syndrome, a phenotype similar to minimal change. Even when a glomerular tip lesion cases demonstrate steroid-resistant, the prognosis is still better than other forms of steroid-resistant nephrotic syndrome. So tip lesion is a good lesion. Not otherwise specified or similar variant, this is the most common, this is the least common type of focal segmental. Now we come to the collapsing glomerulopathy. It is a type of focal segmental, but it is one of the lesion of podocytopathy, has parietal epithelial cell hyperplasia, presumably from injury to precursor of podocyte. You remember when we talk about genetics of glomerulus, the podocyte come from the parietal layer. So parietal cells are not one type of cell. One of them will form the podocyte, and one will form the parietal epithelium. This, it seems that the collapse come from hyperplasia of the cell's progenitor for podocyte, coming from the wall. Electron microscopy may reveal endothelial tubular reticular inclusion when the lesion is associated with interferon or HIV or parvovirus B19 infection or systemic lupus. But no reticular formation, not this tubular reticular inclusion are not present in all lesions such as Permeability. Collapsing glomerular is typically present with acute kidney injury alongside nephrotic range proteinuria. There is, especially if it comes with elderly, or if you have a severe nephrotic syndrome, so there is rapidly escaping fluid from the vascular compartment, rapidly developing hypovolemia and renal ischemia. So ischemic ATN will occur on top of this collapsing glomerular. This scenario can be seen also in patients with membranous nephropathy and sometimes minimal change. You need heavily nephrotic syndrome can cause this ATM. Genetic form of focal segmental cannot be differentiated from other form by morphology. Steroid-resistant focal segmental with a poly-2 allele could have any variant nephrotic syndrome. As other causes, other etiologic causes of focal segmental, you need genetic study. So if you have steroid resistant, think in genetic. Steroid sensitive, okay, it is not genetic. This is another, the last notion in this sector. Proliferative, any proliferative glomerular lesion, such as mesangiocapillary glomerulitis, when advanced, it can have a sclerotic part in the glomeruli, mimicking focal segmental. No, this is not focal segmental. If you examine by electron microscopy, no podocytopathy. The podocytes could be normal, no effacement, no podocyte detachment. So this is not a focal segmental. It is focal segmental on top another lesion. This is not a podocytopathy. The last type is a diffuse mesangial sclerosis, without, of course, without immune deposits such as C1q nephropathy. It can come like this, or IgM nephropathy. No, here we have this mesangial pathology without immune deposits. It is less common finding of podocytopathy. A small proportion of steroid-resistant nephrotic syndrome from a genetic podocytopathy in pediatric population has diffuse mesangial sclerosis and mesangial sclerosing glomerulitis on light microscopy. This is you remember this. This is the head lesion. You remember it? The comma shape, S shape, head shape. This is the development of the glomerulus. This one stage before capillaries being formed. You know, so this is a patient with diffuse mesangial sclerosis. It is the same head lesion. You see this biopsy, patient with diffuse mesangial sclerosis, head lesion. And now it is sclerotic, head lesion in the kidney biopsy. Now, let us leave this story of classification. What is the clinical manifestation of podocytopathy? It can come as nephrotic syndrome, which could be sudden. In permeability factor type, for example, and nephrotic syndrome. It can come only as proteinuria without nephrotic syndrome. Sometimes hematuria can come in any type of podocytopathy, but of course, with proteinuria. Acute kidney injury can occur, as I said, due to hypovolemia, and if a patient takes a drug causing interstitial nephritis, or if he suffer renal vein thrombosis, for example. But if patients go to dialysis, don't lose hope quickly, since this lesion can be treated. You have to wait up to 6 months before saying this is end stage. Okay, now we come to the workup, diagnosis and workup. Clinically, any glomerular disease that cause nephrotic syndrome mimic podocytopathy. Podocytopathy cannot be diagnosed by exclusion, and kidney biopsy is the only way to diagnose these entities definitively. Of course, especially you have to do electron microscopy to document this podocytopathy. This is the different investigation which is done for all types of nephropathy according to the clinical scenario. You chose of these investigations to reach to your diagnosis. What's the treatment of podocytopathy? So now we are going to the end of our story. Classification, clinical presentation, workup, treatment. The goal of treatment of podocytopathy is resolution of nephrotic syndrome and preservation of kidney function. So, of course, salt intake, salt restriction for edema. You give loop diuretic for treatment of anemia. And if you have severe nephrotic syndrome, not responding to diuretic, you may give albumin infusion followed by diuretic to avoid aggravation of hypovolemia and acute tubular injury. You have to give albumin to increase the oncotic force, keeping fluid into the vascular compartment. Of course, RAS in a patient with nephrotic syndrome who you expect respond to steroid, don't give RAS. Otherwise, it can be complicated by acute kidney injury. But give it if there is a patient with steroid-resistant nephrotic syndrome. Immune suppression is a mainstay for treatment, especially for permeability factor mediated. We give, of course, initially, in a patient guy presenting initially by nephrotic syndrome, or patient who was responsive to steroid and now coming by relapse, we give a steroid. The dose is 1 milligram per kg, maximum 80 milligram daily, or you give the same dose but alternate days. So 2 milligram per kg, maximally 120 milligram every other day, at least 4 weeks. So if the patient responds rapidly, this is a good omen, but continue 4 weeks, but maximally 4 months to avoid the side effect of corticosteroid, which we know all. If the course is resilient, start to add other drug beside steroid to be able to decrease the dose. Of course, once you give steroid more than 3 weeks, you have to taper it slowly to avoid suprarenal failure. Long-term use of high-dose steroid is to be avoided, of course, due to fear of avascular necrosis, osteoporosis, bone fracture, atrophic striae, diabetes, and this thing. Now we come to the calcineurin, which we use it commonly, such as cyclosporin and tacrolimus. And here, in contrary to kidney transplantation, TAC is not better than cyclosporin with nephrotic syndrome. So usually we use them to treat this patient. Inhibition of calcineurin will decrease cytokine, so immune suppressive action. But also, besides this immune suppressive action, cyclosporin have an effect on the synaptopodine, which makes the skeleton, which help information of the skeleton podocyte. So not only immune suppressive, but will stabilize podocyte. This may explain using calcineurin in genetic type, and also in our nephrotic syndrome patient, when we gradually decrease the dose of cyclosporin, we have most of our patients are doing very well in good remission with a very small dose of cyclosporin, which is not immune suppressive due to this podocyte stabilizing effect. We know cyclosporin have many side effects. I'm not going to its detail, you know it very well. But of course, if you have patient nephrotic syndrome with hypertension or with renal impairment, we will avoid using calcineurin, but we can use MMF instead of calcineurin beside steroid. There's an interesting paper which compared between giving high dose steroid for nephrotic syndrome, and if needed, you can add cyclosporin. This is a way to treat. Or from the start, you start by small dose steroid beside calcineurin, beside cyclosporin. They compared the two arms. They found that using small dose of steroid and cyclosporin have the same effect of giving big dose of steroid. So you can spare the side effect of steroid by using from the start small dose of steroid and calcineurin. Rituximab, you know, rituximab anti-CD20 is used. We use it as steroid sparing if you have patients steroid resistant or frequent relapser or steroid dependent with side effect. You want to remove, to stop this steroid, and you cannot, since remission occur, you can give rituximab, and this is the dose. You give 1 or 2 doses of this dose. Actually, our experience is good regarding no side effect has been reported. Encephalopathy, which is known to occur with rituximab, we never met it in our patient. Another good point, you have to examine the patient if he is a hepatitis B or not, since you deplete B lymphocyte, CD20. If he is virus B positive, surface antigen positive, be sure you are giving him entecavir. Otherwise, it will flare. If he is B surface antigen positive, negative, and antibody negative, before giving this rituximab, do vaccination first. This paper giving rituximab, patients were on cyclosporin, suffering from this relapse, big dose of steroid. They gave them rituximab. And you see, this is the number of relapse the patient suffered with steroid before giving rituximab and after giving rituximab. This all the patient. So adding rituximab decreased the frequency of relapse. And when they split the patient into adult and children, still the same effect. And according to the pathology, whether focus segmental or minimal change or mesenchymal proliferative, adding rituximab decrease the frequency of relapse. And also adding rituximab, it also decreases the net or cumulative steroid given. So rituximab is good. Corticotrophin or ACTH is another way to treat when there is failure of steroid, calcineurin, rituximab. We give this corticotrophin or ACTH. Why? ACTH will give us endogenous steroid, but we are giving exogenous steroid. It should have the same effect. No, they found that this ACTH, there are special receptor on the podocyte for corticotrophin. So this corticotrophin will give additive effect over steroid. We have here in the Middle East, we have it under the name senactin depot, tetrachocysteine, ACTH, senactin depot. Cyclophosphamide, another treatment modality, but we know that if the patient is steroid resistant, MMF resistant, calcineurin resistant, it will be cyclosporin, cyclophosphamide resistant. So sometimes we use it in certain situations in which we cannot give MMF, you cannot give calcineurin, and you need antiproliferative, so you go to cyclophosphamide. Plasma exchange, of course, to remove the permeability factor. Especially we use it after transplantation when the patient is transplanted and we are facing severe nephrotic syndrome. We do plasma exchange to remove this permeability factor and we increase immune suppression. But usually we succeed in inducing remission, but relapse will occur. So it is economic challenge. Some people believe that this economic burden is better than sending patient to dialysis. But here in the Middle East, dialysis is much, much less expensive than this plasma exchange. So actually, most of our patients are lost from repeated relapse. Also, in native kidney with severe nephrotic syndrome and acute kidney injury, you may do plasma exchange to help prevention. Now I'm going to the end. I would like to, this is the last 2 slides. I will say that podocytopathy also have many corners in our clinical practice, such as in lupus Actually, podocytopathy have a major role or big role in lupus, and we are now more aware about role of podocytopathy in lupus, as we know that lupus, our traditional thinking, affect the glomeruli through either proliferation, you say proliferation mesangial, proliferation parietal, proliferation with crescent, and immune complex deposition in different areas. But now we know that lupus can cause podocytopathy. Podocytopathy can be affected as a part of kidney damage. But here we are talking about podocyte as a target, main target of lupus. And it deserves to be a future lecture, podocytopathy in lupus nephritis. So I will end by this. And you see, this is the recent classification of WHO classification of lupus, class 2, you see lupus podocytopathy, in which by electron microscopy, you will see effacement of food process, which is not seen in the conventional pathology of lupus nephritis. And you can see focal segmental. Even we saw, this may explain, actually in our clinical practice, we have patients with what we call minimal exchange lupus, no change. But the patient who know lupus is coming by severe nephrotic syndrome. What is the explanation? No immune deposits, no proliferation, no crescent, no second base membrane. Why? If you do electron microscopy for this patient, you will find diffuse food process effacement. So this is a lupus podocytopathy, which deserve to be a special issue in next future, inshallah. And thank you all. And I hope I succeeded. I hope to I succeeded to wrap the story of podocytopathy as much as I can, starting from the histology, the pathology, and the embryology of base membrane. And thank you all.
Professor Sobh, thank you very much. It is very wonderful presentation. It is one of the best presentation I attended, and this stimulated me to invite you for another meeting as the expert to have detailed discussion, because hot issues in the field of podocytopathy. I prefer to start the discussion and to take the opportunity that we have prestigious professors and ligands in the field of nephrology to share us in the discussion. I start with Professor Amr Husseini, who joined us from United States. So Dr. Amr, please.
ما شاء الله دكتور صبح، يعني
ازيك يا باشا، وحشني جدا جدا.
ازاي سعادتك؟ ربنا يبارك في سعادتك.
ايوه ازيك؟
ربنا يديك الصحة ويديم عليك العطاء.
ازيك يا حبيبي؟
يا باشا ربنا يخليك. يعني as usual يعني we are trying to learn from Dr. Sobh how to be modern and authentic at the same time. He is the best one with modernity and authenticity at the same time. He just combine this both الأصالة والحداثة مع بعض.
الحمد لله.
Nobody else can do this as you can, Dr. Sobh.
الحمد لله الحمد لله.
We are proud. We are proud.
والله انا براود بيكوا قوي قوي والله.
يا باشا ربنا يخليك.
الحمد لله. ايوه.
Just two quick questions.
ايوه.
First question: when and how often does it help you to order genetic testing for possibility of genetically determined FSGS or minimal change or other podocytopathies? Other question?
Yeah.
Okay, go ahead, sir. Sorry.
Actually, as one of my slides, I said, currently it is a research tool, and we hope in the future when it become less expensive and easy to do. Of course, if this available, it will be one of our routine practice. As now, as I said to you, electron microscopy, now it is one of our routine practice, especially to diagnose podocytopathy. But in our real life in Mansoura here, and I think in many countries like Mansoura, the genetic department in our university, we need to stimulate them to interact with us to improve this area of practice. But actually, we depend on the history and the electron microscopy to say this, and there's of course a response to corticosteroid to say this is most probably genetic. But what is it definitely genetic, and what gene are affected? It need more improvement in the genetic side of our clinical practice.
So you don't recommend ordering it in the clinical practice?
I recommend, but I cannot practice it. But of course, if you have a genetic department and you have facility, any patient with steroid-resistant nephrotic syndrome, do genetic testing for him. Even an absence of family history, sometimes you may have cases with genetic mutation. So I recommend doing it if it is available. But unfortunately, it is not available.
And Dr. Sobh, when we discussed with Dr. Mohsen Al-Qosi, he mentioned that in his center in UK, they order genetic testing as routine for cases of FSGS. But I think I agree with you. The limitation is the presence of a good lab. And I think nowadays, from the clinical point of view, genetic testing is reserved for nephrotic in the very young age, below 1 year, for steroid-resistant cases, and for syndromic cases, if we have nephrotic plus problem in eye, in ear. So in these scenarios, we want to know the genetic defect because it will guide us for the management and for treating the patients after transplantation. And you are dreaming and hoping to have genetic testing at our hand. And the question to Professor Amr, do you have a routine genetic clinic in Kentucky, or it is restricted to metabolic bone disease?
We have a renal genetist. So if we have good possibility that this nephrotic syndrome or any other kind of, genetically determined renal disease, we have genetists. So we send the patient to the genetist who do the, orders the test. But I can just summarize my experience just in one single sentence. Genetic testing doesn't help to treat patient. It helps not to treat.
Good, very good. What I said, yeah.
Right.
One of the slides I said it to help us.
It helps not to
give immune suppression,
Right.
Yeah.
Instead of wasting, resources and giving toxic medication to the patient, you would decide that this patient is probably not going to respond.
Yeah.
My second question, sir.
Yes.
Do you have an evidence that losing weight or bariatric surgeries can reverse the FSGS, the adaptive FSGS, or it would just only slow down or retard the progression of the disease?
Okay, very good. Okay, very good. Of course, from the pathogenesis side of you, you have obesity, you have hyperfiltration. Okay, so hyperfiltration, of course, if we do bariatric surgery early, we will prevent any structural damage. You stop hyperfiltration, everything will go normal. Just it is hemodynamic at the beginning. But by time, some of the glomeruli will be sclerotic. And the remaining will be more hyperfiltrated and sclerotic. At any point when you do bariatric surgery, okay, if you have sufficient viable glomeruli still there in the two kidney, hyperfiltration will stop, and still you have sufficient kidney tissue for normal life. i.e., the damage affects the kidney reserve. If you only take from the reserve and you stop the disease process, kidney can continue normal. But the more you consume the reserve and start to take more glomeruli, you will have permanent damaged glomeruli. Permanently damaged glomeruli is irreversible, of course. Irreversible. It depends on how far or how number of glomeruli is still viable. The more the glomeruli, the shorter, the more the glomeruli, the longer the free of proteinuria the patient will be. But the more damage occurred when you did bariatric surgery, the less good expectation. I mean, if you do bariatric surgery early and we are just hyperfiltrating and proteinuria, or few glomeruli are sclerotic, and you did bariatric surgery, you can stop the disease, or you have sufficient kidney tissue to live good shape long time. But the delay is the bariatric. The shorter the survival of remaining kidney tissue. When the glomeruli are sclerotic, this is irreversible. But if it is hyperfiltrating, this could be reversed if there is sufficient number of glomeruli. But suppose you did bariatric surgery and more than 50% of glomeruli are sclerotic. Okay, the remaining glomeruli will be still hyperfiltrated. Of course, you will committing hyperfiltration will be less after doing bariatric surgery, but it will persist due to the fact that big number of glomeruli are lost. قادر اوصل الرساله؟ يعني the earlier you do bariatric surgery, the longer the survival of remaining nephron. In my practice, معايا دكتور عمرو؟ الو؟
انا بفتح عليها يا دكتور محمد لانه قطع على
Yes, sir. Yes, absolutely.
In my practice, for example, I saw many cases like this. The last one was a man from Cairo. He came as obesity stage 3, more than 40. And actually this patient came to me with nephrotic syndrome. And he was obese to the extent that he cannot lie on table to be examined. Usually I examine him while he is sitting. Always his mouth is open, his tongue is much fat. He was terribly obese. And he spent his life going to hospital for intravenous albumin and diuretics. I said to him, you have nephrotic syndrome. This nephrotic syndrome is mostly your morbid obesity. There is a possibility that he has membranous. Yes, I know. But he was morbid obese. And spent his time, as I said, nephrotic, severe, heavy proteinuria. And by time, I said to him, this kidney will be damaged by time. And by time, his creatinine started to go up 1.5, 1.8, 1.2, 2. I said to him, this is a story which I said to you, you have to do bariatric surgery. He was too tired after 5 years struggling with his proteinuria. I said to him, he asked me, Dr. Sobh, what do you advise me? I said to him, if I'm you, I prefer to die, not to live like this. Go and do, go and do bariatric surgery. But you will be lucky if you find an anesthesiologist who can do for you anesthesia and surgery. Actually, we have good surgeons in Egypt. This is true. They are good surgeons. He went and did surgery in Alexandria. And he came to me, this is what I say. He came to me, he never went to hospital. He is proteinuria free. His creatinine started to go down. This man became a slim person. Slim man. His proteinuria vanished. But his creatinine is going down and stayed at 2.1. So he has a residual kidney dysfunction, some tissue damage from his long-standing obesity. That's what I say. Hyperfiltration at the beginning from obesity. But by time, additional hyperfiltration due to some nephron are sclerotic. When you treat obesity early, no sclerotic glomeruli, he will come normal. But if there is sclerotic glomeruli, the more these glomeruli are sclerotic, the more the hyperfiltration will be persistent despite bariatric surgery and losing weight. This is my answer.
Dr. Amr, if you allow me just a comment about this point. Regarding the evidence, it is hardly to find randomized controlled study, but reviewing all registries of metabolic surgery, I think one of the best advantages of bariatric surgery is the kidney. So macroalbuminuria, albuminuria in the modest degree, albuminuria stage 2, A2, chronic kidney disease stage 2 or 3, all these improve significantly with bariatric surgery. This is why if the patient is on maximum medical treatment, I advocate not to be delayed in doing bariatric surgery. And now I'm advocating laparoscopic sleeve gastrectomy because side effect can be tolerated and can be managed easily. And I have the registries for more than 100,000 cases published all over the world, showing even diabetic microangiopathy is reversible after bariatric surgery. And I would like to hear from Professor Amr. Do you have any data or any suggestion in this point?
No, I don't. I mean, you know, all of the data I have is just either small retrospective studies or not very well designed studies. But I'm just curious if you guys have any evidence rebiopsying patients after losing weight and seeing regression of the FSGS. But this is phenomenal presentation, Dr. Sobh. I cannot stop learning from you, sir. For almost 30 years now, I'm learning every day. You are teaching us, sir. Thank you so much.
And your opinion, Professor Amr, about my suggestion to have another session just to discuss the hot issues related to podocytopathy with Professor Sobh in the expert session. Do you agree with me? Yes.
Absolutely,
so
of course.
We can invite many experts to join us in this meet the expert with Professor Sobh. And before the session, I announced that the audience, it's better to review the video of that mentioned by Professor Sobh, and then to have the chance for many questions and to change experience. And I thank you very much, Professor Amr, for your contribution in sharing this meeting.
Thank you, sir.
Dr. Hala Al-Wakil. Unmute yourself, Dr. Hala. Yes.
السلام عليكم.
وعليكم السلام.
يعني it's يعني amazing الحقيقة, amazing talk الحقيقة, من الجينيتكس للباثوفيسيولوجي للفور تكنيكس بتوع البودوسايت انجري, الكلينيكال امبليكيشن. الحقيقة marvelous. يعني thank you very much. I have a lot of questions, بس انا هذاكر الاول لاني فعلا انا ضروري الباك ريفرنس اللي حضرتك حاططهم والمحاضره القيمه دي ضروري هقراها تاني. ف
يعني انت بتضم صوتك يا دكتوره هاله للميزه اكسبرس.
مفيش مشكله خالص, بس هذاكر بقى بعد الكلام اللي الدكتور صبحي قاله. انا هذاكر جامد يعني. ثانك يو فيري ماتش. والحقيقه استاذنا دكتور صلاح نجا كان دايما بيعمل لنا ابديت للفوكال سيجمنت بعد ما يجي من الاي اس ان ميتنج انيولي, فممكن نانفايت برضو استاذنا دكتور صلاح نجا.
يا ريت يا ريت يا ريت
في هذا الموضوع, وانا هديله فكره. ثانك يو فيري ماتش استاذ دكتور صبحي.
دكتوره هيام
شكرا جدا. شكرين.
العفو بيه.
دكتوره هيام بليز unmute yourself. دكتوره هيام. اوكي.
السلام عليكم.
اهلا دكتور هيام.
انا دكتور.
ازي حضرتك؟
ازي حضرتك بخير.
ازي حضرتك؟
والله انا يعني very stimulating, والحقيقه يعني يمكن الواحد مش ناسيها, انما يعني موضوع ما كانش في الذهن قوي. انما الحقيقه هو very very practical. والحقيقه انا بشكر حضرتك جدا والدكتور حسين على كميه المحاضرات والاميننت بروفيسورز اللي بيقولوها. الحقيقه يمكن ما فيش اسئله معينه، انما ده هيخلينا نفكر شويه، مش اي نفرطك كده زي ما كل الناس بتديهم بدايه ستيرويد وإيمونوسابريسيف. لازم الواحد يفكر وات از ذا ايتيولوجي عشان يقدر يعني يمشي في المكان الصح. فالحقيقه انا بشكر حضرتك جدا جدا، ويعني فيري فيري انترستنج. وكويس ان الدكتور حسين بينزلها على اليوتيوب، لان دي برضه الواحد بيحب يعيد يسمعها تاني وثالث ورابع كمان. نشكر حضرتك جدا. شكرا
اشكرك جدا جدا دكتور هيام.
والله احنا
شكرين.
سعداء بحضرتك
يعني من
وكل
الناس
المجموعه.
اللي بيسعد بمجرد سماع اسمهم او صوتهم يعني.
الله يبارك في حضرتك.
أو
سلامنا
متشكرين
للجميع. شكرا جزيلا.
متشكرين
شكرا.
متشكرين
مع السلامه.
متشكرين مع السلامه. مع السلامه.
انا طبعا باسم الناس باسم كل الاساتذه والدكاتره اللي حضروا معانا النهارده، وباسم الناس كلها اللي هيشوفوا الفيديو على اليوتيوب، بشكر طبعا استاذنا الفاضل الدكتور محمد صبحي على هذا العرض الرائع، يعني الغير تقليدي. وزي ما الدكتوره هاله قالت والدكتوره هيام والدكتور عمرو قال، يعتبر ده فعلا اطلس لللوبس بودوسايتوباثي. وان شاء الله باذن الله هنرتب مع استاذنا الدكتور صبحي سبيشال ميتنج، نبقى فيه اسئله كثيره جدا، لان في كلام كتير جدا عاوزين نتناقش فيه. بنشكر حضرتك.
شكرا شكرين انا بشكركم والله.
والسلام عليكم ورحمه الله وبركاته. مع الف سلامه.
مع السلامه.